And we are going to start webinar now.
Good afternoon, everyone. I'm Frances Padilla, President of Universal Healthcare Foundation of Connecticut, and I'm delighted to welcome you to another one in our series of programs on Beyond COVID. This one is going to be about hospitals. Hospitals will never be the same. This conversation is part of For This Year about what the lessons of the past 18 months tell us about the future. In our earlier programs, we've spoken with leaders of community health centers and the local public health systems. Today, we're focusing on hospital leaders and hospital systems, and in November on behavioral health. We have two great panelists who I will introduce shortly. But first, please let me thank the sponsors. Thank you to the Eastern Connecticut Health Network, the Foundation for Community Health, and to our parent organization, CHART, who are series sponsors and supporters. Our program today is also sponsored by Stamford Health and Trinity Health of New England. Eastern Connecticut Health Network has a video that they would like to share with everyone, and I'm going to ask my colleague Rose to run the video.
Healthcare Foundation of Connecticut. Thank you for joining us to hear more about how healthcare providers across Connecticut are expanding ways to promote high-quality healthcare that's affordable for everyone. We believe in providing exceptional and compassionate care for our region, and we also believe in providing helpful tools and information to stay connected and informed about healthy choices. Our mission is to partner with you in making healthy happen for you, your family, friends, and our community. I hope you enjoy today's discussion. Thank you.
And thanks to Deb Weymouth at Eastern Connecticut. I want to start with introductions. I'd like to introduce Kathleen Salard. Kathy began her career as a nurse in the pediatrics and neonatal intensive care units at Albert Einstein Medical Center in New York, before entering the field of healthcare administration. After serving as Executive Vice President and Chief Operating Officer at Stamford Health for 15 years, she was promoted to President and CEO in 2018. She piloted Stamford Health through the COVID-19 pandemic, caring for hundreds of patients, collaborating with community partners to serve at-risk populations, and forging a unique partnership with the military to set up an alternative care site that was a regional resource during the spring surge last year. Dr. Reginald Eadie was born and raised in Detroit, where he began his journey by becoming a physician board certified in emergency medicine. He then turned to a career in hospital administration, serving as chief medical officer and then hospital CEO at 4 different Michigan hospitals, and as regional chief operating officer for the Detroit Medical Center. In 2018, he joined the Trinity Health of New England team as president and CEO, overseeing a system that includes St. Francis Hospital, 3 other Connecticut-based hospitals, and Mercy Medical Center in Springfield, Massachusetts. In September 2020, he was appointed the co-chair of the governor's COVID-19 vaccine advisory group in Connecticut. Welcome to you both, Reggie and Kathy. Thank you so much for making time to be here with us today. I want to just alert our audience that we want this to be a conversation with their participation as well. So I encourage everyone to put your questions into the question and answer function on the bottom of your screen, Q&A. We're also recording this conversation so that we can share it with those who aren't able to join us today. But I'm going to move right in. We have a lot to talk about in the hour we have together. COVID and racial reckoning laid bare how dysfunctional our current healthcare system is. Even though we are talking about beyond COVID-19, to look ahead, we understand that we are really still in COVID. We're still working through it. But we need to try and understand the lessons that we're learning and about how to break down silos and refocus on being a truly people-centered health system that connects health, care, and community. So in our prep conversation with you, you both reflected on how your hospitals have been forever changed. And it would be really, I think, interesting to hear from you, your stories, a story about how that really played out. Would you share a story that highlights how COVID took you to the next level in working with your communities? How did your own roles as leaders change? Want to start, Kathy?
Sure. Stamford Health was a hotspot, and we're a safety net hospital. And during COVID-19, because of our proximity to New York, we had that wave very early as it was coming up the I-95 corridor, and we began to receive patients extremely rapidly. And we had to mobilize very quickly in order to be able to anticipate not only what we thought was happening today or tomorrow or the following week, but what would happen several weeks to come. And we saw what was happening in New York, which was scary. And when we saw some of the concerns around shortages of supplies and staffing resources, et cetera, we began to think about what that meant for us. So we had to do an enormous amount of planning. But I will never forget a day I was walking in the ICU, and we expanded from 20 to 73 ICU beds during the pandemic. And one of our critical care doctors came up to me and he said, and this conversation wasn't even really happening that much on a local or a regional or even a national front at that point in time. But he said, Kathy, something is really wrong. I am seeing so many more sick Black and Hispanic patients from our community. It is really disproportionate in terms of how this group is being impacted. And so we knew then that we had to do something. And that at that point, it was not about vaccination. It was around education, around masking, social distancing, how this disease evolves and spreads, and also the impact on those individuals who are at risk groups, whether it's because of congregate settings or that they were living in, or because of comorbidities that would put them at a greater risk. So it was so eye-opening for us to see a segment of our own population in our own community so impacted that we knew we had to jump into action. And like any healthcare organization, we were struggling at that time just to try to be able to do what we needed to do for our inpatients. So we did a ton of outreach into the community. We belong to an organization called the Vita Health and Wellness Group, and it's an assemblage of not-for-profit organizations like the City of Stamford, Charter Oak Communities, which is the former housing authority, Board of Education, a bunch of nonprofits like the NAACP and Building One Community that cares for the immigrant population. And we said, we need your help. You have relationships, you have community tentacles that are far more important and impactful than those that we have, but working together, we can get out there and get the message out about what has to happen in order to stop this tsunami.
And so you already had some relationships in the community that you could build upon.
Yes, we did.
In the community. And that is really so essential. How about you, Reggie? How about your experience in Hartford?
Yeah, sure. And first, let me thank Kathy and her team. Because of their proximity to the state of New York, we learned a lot. We were able to sort of look down in the lower part of the state and see what they were doing, how they were doing it, and what experiences they were having, which better prepared us as things migrated north. So if I remember correctly, Governor Lamont confirmed the state's first COVID case, I think it was on March 8th of 2020. So since then, healthcare, as you alluded to, Francis, and the way we service communities will never be the same. And why? I think primarily because of what we learned on how to better care for our community. So for example, when we initially set up drive-through testing across the state, we required prescriptions. I'm sure you guys remember. But we forgot about how difficult it is, even when we're not in the pandemic, for many residents to access the primary care provider. So we failed there, but we learned from that. Next, we realized that we forgot about the approximately 50% of Connecticut residents who don't even own a car. So we learned from that and eventually allowed for testing to occur for people by providing a walk-up lane. But we continue to learn. We also forgot about, in America, some 25% of us live greater than 10 miles, if I remember the stat correctly, from the nearest hospital. So walking, when you think about the handicap or the elderly, that's not viable in this situation.
Not an option.
So if you think about that, we created a system that marginalized, although not intentionally, marginalized populations. And we were at that time starting to talk about the impact of systemic racism. And many people didn't really understand how that thing even could exist. But here's a great example of how me, a CEO of the third largest healthcare system in the state, created a system that marginalized people. So that's systemic in nature. And then finally, we realized that we needed to do more talking to, listening to, and making it easy for the communities that we serve, instead of, I say, creating a strategy independent of their input. So we got it right with the testing. And this is how and why, I'd say, we ended up creating the 24-hour Vaxathon, where we took the vaccine to the community instead of asking the community to come to us, as we did in testing. So this allowed for thousands of Connecticut, I mean, this is an amazing event, for thousands of Connecticut residents who, for example, had to work during the hours of the pop-up clinic, which were usually bank hours, if you remember. They couldn't access the center for one reason or another. And then there was a population of people in Connecticut that couldn't access VAMS and make an appointment, because remember that too was necessary.
The system, just for our audience, remind them what VAMS was or is.
VAMS was the access tool that the state adopted for its residents, to citizens, to make an appointment at a vaccination center. And so, people didn't have internet, people didn't have the IT savviness to even go through that process. So these were people that we created a system that, again, were marginalized. So that 24-hour Vaxathon allowed for us to sort of bypass all of those barriers that we put up for the communities. We were seeing generations of families getting vaccinated. So here's an example of us, how we listened to them and then serviced them the way they wanted and needed to be serviced, as opposed to the way we thought they needed to be serviced.
That's a fascinating, really perspective on starting with the end user first, and they're putting yourselves in their shoes. I remember a story that Kathy also told us during the conversation we had a couple of weeks ago to prepare, about the Afghani woman who was afraid of going into the hospital. And there you were able to empathize. And I think that empathy is such an important part of how healthcare is most effective, and quite often because of the insurance requirements and all the various regulations and policies that exist, as you noted, Reggie, that actually make the system marginalize the very people that it is supposed to serve. So how do you there's a question in the chat that I'm going to actually pose to you right now, because I think it is relevant. And it's, how would your management of the COVID pandemic been changed if all your patients had their healthcare costs covered, if you didn't have to navigate different insurance policy coverages?
Well, Kathy and I, although we're business people and we have to wear the business hat as we manage hospitals, we can't even pre-pandemic, we don't really look at the insurance status of a patient. So that was not a barrier that we had to deal with. I mean, listen, at the end of the day, we're a mission-driven company, and we often say, and the sisters remind us in the Catholic space, no margin, no mission. So we appreciate that and we take that serious. But the insurance status of an individual who was in need of care did not impact us at all before the pandemic, and certainly didn't do so while we're still, I'm speaking as if the pandemic's over. So we still don't do that, and won't do that in the future, although it's very important. So, but what I will say though is when you think of the way we've offered the service to the community, things are a little different. So I can tell you that of our 5 hospitals, only 1 really had engaged in telemedicine. Now all of them do, and telemedicine is here to stay, of course, as long as we get reimbursed for that type of care. But that's just one example of how we're doing things differently. And as I alluded to in the opening story, I mean, we have to do a much better job putting our thoughts to the side. I mean, you know, Kathy and I have experience in this space. We think we do a pretty good job in managing the hospitals, but we also realize we're not as smart as we think we are as it relates to how to individually service a person or a family or a community. And so we need to do a better job in reaching out and asking how he or she or that group of people, that population, best wants to be served, and then we need to serve accordingly.
Yeah, I agree with Reggie. During this period of time, if we're mission driven as well. We're a not-for-profit organization, and all of our any margin that we have, and hospitals operate on razor thin margins, but any margin we have gets reinvested in the organization for technology and people and being able to, you know, stay on the cutting edge of medicine. But I have to say that during this pandemic, I did not worry about what I was spending at all. It was a public health emergency. And one thing that we realized very early on is that there is no public health infrastructure or organized system, not just in our region or our city or our state, but across the United States. And that the hospitals became the de facto public health system. But to Reggie's point, listening to what was going to be impactful and bringing those groups that I was articulating together to say, what's going to work? How are we going to reach this population that is so vulnerable? So for example, in the Black population here in Stamford, the relationship is with the churches for the most part. And so working with the NAACP and the city of Stamford, we have great relationships. We said, how can we reach that community? Well, it's through the ministries that they have in the community and the pastors that would have the conversations with their congregation about how to prevent this illness, how to get help if you need testing or you need some sort of care. And similarly, with the immigrant population, we realized that a lot of the fear around this was not, or even seeking healthcare was they would, because many are undocumented, that they would become vulnerable with their documentation status. So for the vaccine, we did a program called No Barriers, where we went out into the community and we put the word out. You can come in to get your vaccine. You don't need an appointment. You just show up. You don't have to show us any documentation. You don't need insurance. We had interpreters that spoke in their language and that were culturally similar to them to be on site to help them through what was or could be a very scary process. And similarly, we wound up going door to door as well, because we just realized we weren't going to get everyone in, even with that extraordinary program.
I understand that you went door to door. You also hired local people to do that. So these are all like in this moment, right, of crisis. It's a public health crisis, and your institutions both rose to the occasion. What is it about this experience that will permanently change the way you work in your respective communities?
Well, I'll start with a very concrete example. When pre-pandemic, we were in the process of getting ready to kick off a behavioral health assessment of our community. Look, the problems with behavioral health and access to mental health didn't start with the pandemic. It was a big problem long before then, but it's now been magnified and exacerbated by all the stressors in our communities. But I think previous to COVID and the experiences that Reggie and I and other leaders had, we probably would have had the consultant come and help us, and we would have gathered just the people that we think are experts in our system around mental health, and we would have crafted a plan. But this time we did all of that, but we invited the community to come in and talk to us about what they saw as the mental health needs. So the members of the police department, the social service agencies, the food banks, the homeless shelters, the Liberation House, which is a recovery program. And we said, what are your boots on the ground out in the community? If we're going to, what is the gap in our resources for this community, and how do you think we can work together to leverage our collective capabilities to meet the needs better? So I don't think we would have been so thorough in making sure those voices were all at the table. Because I think, to Reggie's point before, we probably thought we were smart enough to know what they were thinking, and maybe we learned we don't. Not a maybe, we know we don't.
And more heads are better than a few, right?
For sure.
Well, as we've said, we're still living through the pandemic. And so having gone through the surges of the past 18 months, here we are with the Delta variant and back at it, perhaps not as acutely as, Connecticut has done pretty well, but you're still dealing with it. So how are your hospitals doing now? How have you been able to draw from the lessons of the last 18 months for the current crisis, and how's it going?
Yeah, so it's not novel information that this region of the country is the safest as it relates to the pandemic. So, my hat goes off to everyone who is participating in getting us through to this point as safely as possible. I mean, as you indicated, the Delta variant is the prominent strain of the virus in Connecticut. And so we continue to care. We've never had 0 patients in our system since the pandemic started. What we're seeing now, so let me say this also, because we learned from the southern part of the state and their experiences. So thank you again, Kathy, for that. And we went through what we went through. Plus, I think we did a great job. We've got great leaders in the state who got us to where we are. Today's total within Trinity Health of New England census of COVID patients is 31. While that's 31 more than we'd love to see, it's very manageable because of what we've learned. We also realize that this is a pandemic of the unvaccinated, right? Our stats show that 75% of the people that are admitted in the hospital and almost 100% of those that are in the ICU were never vaccinated, right? So it reminds us that although we've made a lot of progress, and the rearview mirror in the automobiles is small compared to the windshield, because you shouldn't spend a lot of time looking in the past. But it's worth looking in the past is to understand, how we got here, although we've done a great job, and what else we need to do, back to the windshield, to ensure that we continue to be successful as a region and as a state.
Yeah, we're similar in a similar situation. I think we all did a lot of work to pivot as quickly as possible back to pre-COVID operations, because people didn't stop having babies and unfortunately getting cancer diagnoses or having heart disease and strokes and other issues. So and we continued to care for those individuals during the pandemic as well. But we're really now very focused on prevention. What are the things you need to do? Get back to your primary care physician and make sure that you're doing all of the things you need to do to preserve your health, get your screenings, make sure that you're monitoring your health status and follow up on all of those things. We have a census of around 11 this morning, very, and manageable, and exactly the same experience as Reggie. We are about 75% of the individuals who are hospitalized are unvaccinated, and almost none in the ICU. So people are less sick. But make no mistake, this disease is still very bad because some are still dying. And so you getting us to over the heap, in the road around vaccination and making sure that people are getting their preventative care is going to be very important.
It will be a continuing need. It's a sort of another layer that we will have to acknowledge and recognize and accept as part of the care that needs to be provided moving forward. So I think this is a great segue actually to how is it that some of the positive changes and relationships, new relationships or deepened relationships that you've been able to cultivate that have emerged from this crisis, that how do we hold on to those and not return to business as usual? And you alluded earlier, right, to telehealth, telemedicine. And we know that during the pandemic, there have been a lot of exceptions made in order to cover the cost of telemedicine. And it isn't, a shoo-in that telemedicine will continue. Telemedicine is not a substitute for face-to-face healthcare either, particularly for different population groups who might really need to have that. But what are the options, right, moving forward? Reimbursement does continue to be a challenge, and we've read in many articles and reports that hospitals are feeling the financial pinch or feel like they're feeling the financial pinch, even though from a moral perspective and a care perspective, you're committed to caring for everybody. So the question is, how do you hold on to those positive changes and not return to business as usual?
Yeah, I'm happy to answer that. So listen, there's not a lot of positivity or silver linings that I can think of and talk about comfortably as it relates to the pandemic. But if I had to come up with one, I'd say the relationship, as you were alluding to and asking about, the relationship buildings that took place. So, I'm reminded, and listen, I am totally an apolitical person, and it is not my favorite place to be in a room with legislators. But I found myself in that predicament a lot, and that's a silver lining here in this pandemic. So partnering with the legislator, listen, it takes a village to get us through this pandemic, and we can't afford to leave one person behind or one empty seat at the table. So, having conversations and develop close relationships with legislators, Department of Public Health, many community-based organizations was very necessary. And so my response to your question is we need to make sure we continue that as we transition, and I'm speaking optimistically, quickly out of this pandemic, right? Because we understood, we understood that we really didn't understand what was going on in each community. And so we were making decisions that, again, was not in the best interest of communities and creating a system that marginalized them. So we need to figure out a way to continue to have that conversation. It's because of the people that are at the table, that because the pandemic forced us there, that we are in a position that we're in now, which is a favorable position, in comparison to a lot of other regions in the country. So continuing or perpetuating that conversation and relationship, not only to prepare us for the next pandemic, because there's going to be another one, but there has always really been a pandemic when you think about systemic racism, social determinants of health. I mean, that's always been there. And it was illuminated very quickly for all to see when the pandemic hit. So we've got a lot more to talk about and a long way to go to get through those other type of pandemics that we're faced with every single day in healthcare.
That's right. And, the way that both of you have described changing how you work with community is, a prerequisite really to addressing racial, ethnic, socioeconomic, and other disparities that exist in Connecticut and exist around the country. But here we're talking about your particular systems and your particular communities, and how to build and maintain the connections necessary to influence policies and practices of your institutions and also of government, and how it, how it interacts with the healthcare system. So, Kathy, your thoughts about that?
Yeah, I agree with Reggie that the opening those conversations, I too am mostly an apolitical person, but working with our governor, who I think did a great job navigating us through this. And he listened, he called the different constituents and said, what's going on where you are, and what do you think we need to do? I have to say also, I think there was a great collaboration between the CEOs of the hospitals in the state. Mm-hmm. We compete with each other, and we collaborate around themes of care, but we don't always collaborate around the individual patient. And during COVID, I remember saying, I think we're going to be in trouble, when we called the military in, and the other CEOs called and said, what can I do? What can I send you? And they sent me ventilators and staff and resources. And then once our numbers began to wane a little bit, and we had the military here, we opened up that convalescent unit, and we said to the other hospitals, because then the wave was going up the state, if you're overwhelmed, send us some patients and we'll help recover them. Because at that point, no vaccine, we didn't want to send people who were recovering home to infect people who were vulnerable at home. So we had to keep them a little bit longer. So those kinds of collaborations became really important. And I think if this nation does not have the resources to invest in a public health system that could be ready in a pandemic, so then let's let that dialogue continue between all the leaders that have an impact on this outcome for our country and state, to keep talking about how we can help each other. I think one important piece I would want to mention, you can't but recognize the impact on the workforce that has occurred as a result of COVID. Whether it's, and it's not just healthcare, it's different ways of working, people becoming unemployed, frightened, losing loved ones. And in healthcare, we're very focused on the impact to our own healthcare workers. And what are we going to do for the future to make sure that pipeline continues? That they're resilient, that we're supporting their needs, so that this still continues to be an attractive place for people to seek jobs and to seek careers. So that's another big area that I think COVID highlighted that we need to pay attention to.
Yeah, I remember sitting back in like May, June last year and thinking about what the impact of the pandemic would be on the workforce, and the number of people who would leave medicine actually because of the feeling of maybe being thrown under the bus, or just the overwhelm of being there day to day, facing death in the face, right? Mm-hmm. And so the workforce is so critical, and we're still having to attend to it for the foreseeable future, attend to the mental health needs of the workforce as well as other needs. So how do we, Reggie, you alluded earlier to the fact that our region is one of the safest regions, in the country. You're CEO of a system of multiple hospitals. And we've been talking predominantly right now about Hartford, St. Francis Hospital in Hartford, although I think you've been a little bit more general, but you are working in different communities. Were there differences in how you were able to work as a system in the various communities? And I know one of your hospitals is actually in Massachusetts. Are there any reflections you have there about what the differences were and what the positive and negatives of that might be.
Absolutely. So I'll start with the Connecticut Hospital Association. And as Kathy alluded to earlier, I mean, we had regular phone conversations, seemingly almost every day during the first peak. And so it was very organized. We were visited by the governor or a representative from his office oftentimes. And so we were on one accord, and we created the strategy and provided the support that each of us needed to get through that first peak. When I look at the Massachusetts Hospital Association, because as you suggested, we do have a hospital in Springfield, Massachusetts, the MHA was not doing that. When I compare the state leadership and the strategic planning, the responsiveness, they were like night and day. This is not to criticize the leadership in Massachusetts by any means, but it was very palpable, the difference between the organized approach to addressing and getting through collectively this pandemic or that part of the pandemic in comparison to the neighboring state. We were more aligned, I think, with the New Jerseys and the New Yorks as the state of Connecticut, but Massachusetts seemed to be doing its own thing for one reason or another. So yes, I was able to, I mean, just something as simple as testing, right? So there were limited testing, early on, there were limited testing centers in the state of Massachusetts as opposed to Connecticut, where it seems like we were competing with each other to test as many people as you possibly could. So yes, there was a vast difference in leadership, strategy, implementation, et cetera, between Connecticut and Massachusetts.
It's pretty interesting when you think about Massachusetts and its history of the strive toward creating systems change in making care more accessible and affordable to everyone, and its relationship with the hospitals particularly. I have a question about from the Q&A from our audience that I'd like to pose to you. We have a few. Do you anticipate that individual hospitals will continue to decrease certain services? For example, we have a hospital here in Connecticut that has suspended labor and delivery, and it seems unclear if this will be temporary.
Yes, I don't know if that's directed to me, but I'd be happy to.
So either one of you, both.
So if you listen to what Kathy was saying when she talked about the colleagues that she works with every day, I mean, we saw and continue to see, and when the deadline or the end date for the vaccine requirement comes up in all of our hospitals, we will see even more of our colleagues leave the healthcare space, at least being this close to the bedside. So what we're forced to do, and this is what we've been doing since March of 2020, is to reinvent, transform and reinvent the care models that have been in place for many, many years. Now, listen, we need to do that, but this pandemic has forced us to catalyze the change. So because of the workforce that's just not available in many hospitals, and I'm unaware of the hospital that's decided to do it, but I would guess that the reason why they're doing that is because they don't have a choice. I mean, our commitment to the community in this healthcare space is to only provide a high quality and safe care to the citizens that we serve. And to the extent we can't do that, then we've got to make tough decisions. And if you don't have the providers, and especially if you think about who spends the most time with the patient, it's the nurse. And that's one of our most challenged areas in healthcare, it's nursing. And they're not, the hole in the bucket is much bigger than the inlet of nurses coming out of nursing school. And many of them don't want to be near the bedside or take care of patients. So that this is not just a pandemic problem. This was a problem before the pandemic. But again, the pandemic just brought it to the forefront, and it's not going to get any better anytime soon.
Well, it feels to me like this is an example of where we really do need we do need a strategic plan for our state around healthcare and the systems, a systematic plan for filling those gaps. We've needed it for a long time. We've had a nursing shortage for a long time. And where is what's government's role in this? What do you think government's role should be?
Well, even during the pandemic, Governor Lamont had a workforce development task force that was looking at the impact of what was happening, especially for businesses that were closing, where people were losing their jobs, and what could be done to help those individuals navigate to new positions. And actually, many hospitals participated, and we participated, and we worked on taking about 25 people who were displaced in the hospitality business, restaurant, hotel business where they closed. And we work with the community colleges and retrain those individuals to become central sterile processing technicians, and to work in housekeeping or in receptionists in our healthcare system. So that was a very effective group, and that group is actually being expanded and reconstituted. I'm actually going to be sitting on that statewide, working in collaboration with businesses to look at what are the unmet job needs in our state, and how can we make sure that we're working collaboratively with the community and other academic institutions to develop the workforce that will allow us to continue to survive and thrive. And I'm sure Reggie does this as well. OR nurses are a particular area of shortage. They're not out there. They're just not enough of them. And so we're training our own. We're running a course right now to train 8 operating room nurses. It's an investment, because those nurses will be working for a year to 18 months without being productive, or will be training, I should say, for a year to 18 months without being productive. But that investment in those individuals will pay off in the future.
Longer term. And that really, I mean, at the end of the day, when you think about this, this is all about, if it's patient-centered, it's because you want to be able to provide and maintain the services that are needed at the community level. So the labor and delivery example that this question is about is an example of, you know, resources that are needed in the local community. People are having babies. They shouldn't have to be driving, you know, miles to have their baby at another hospital. But the investment in being able to receive them and to maintain those services in an affordable way is really critical. And we know that both you and both of you have been engaged with the governor's efforts at healthcare affordability improvement and the Office of Health Strategy. And there's a question in the chat about that, in terms of, I mean, you've been being part of that discussion around how does Connecticut really address healthcare costs, which are higher in Connecticut than they are in other parts of the country, and not necessarily with better results, right? Better health outcomes. So you've been doing that during a period when you're also, as you said, both of you said earlier, doing what needs to be done without thinking about how much it costs or who's paying for it. How do you view these efforts at affordability and really reshaping and reimbursement, you know, reshaping and resizing our healthcare costs in Connecticut?
Yeah, so so this is where Kathy was saying how the pandemic brought all of the leaders together, but we did not come together for individual health system or hospital strategies. So yeah, so I'm what I'm saying now, I'm only speaking on behalf of Trinity Health New England. So we pay a lot of attention to the value proposition equation in healthcare. What that is you just think of the numerator, the top of the equation. We look at things like patient experience, safety, quality, etc. And then the denominator is just one item, and that's cost. And so it is our position that it's our responsibility as a faith-based organization to increase the value proposition, or improve the value proposition, or increase the value of our offerings. And so we do that by making sure our cost is low as possible, and we provide high quality and safe care. And there are measuring rods out there, not ours, but there are measuring rods from many agencies, like the star ratings, up to 5-star ratings. So we want to be a 5-star. We want all of our hospitals to be a 5-star hospital, and we're getting there. There are leapfrog scores around safety and quality, and we want all these frog score A's. And so most of our hospitals are now A's. And so that is really our strategy. Then, other healthcare systems don't really have that as a strategy. They want as many people in their hospital as possible. And they're still looking at the volume. We're not looking at the volume, we're looking at the value. And so that's a different strategy. We believe that the value proposition is what the state leadership should be focused on, because we need to drive down the cost. Connecticut is expensive enough to live in, right? So the last thing we need is for healthcare to be so expensive. And Kathy and I partnered on some committees to work on that. But we have a long way to go as a state. When you look at Massachusetts, you look at a state like that I came from, like Michigan. I mean, they've mastered lowering the cost of healthcare, which is what we want from a universal perspective, because universal means everyone, right? So I continue to push the legislators to remember that it's not about the volume, it's about the value. It's not about the expansion of a healthcare system. It's about the quality and safety of care that's affordable, that's offered to the community.
Yeah, I agree with that. It is the value, and we have established some benchmarks, and in states that have established benchmarks and work to achieve those, they bent the cost curve. But I think it's broader than just a benchmark. It's really focusing on prevention and getting out into the community and making sure that people are doing and getting the kinds of things that will keep them well, as opposed to getting sick and needing to come into the hospital. It's about eliminating waste. There's a lot of waste in healthcare across the system. And also it's about making sure that you have appropriate end-of-life care. For people who, especially those who have terminal illness, that they have all the information at their fingertips about how they can live a very satisfying life and not have a very unsettling end of life where a lot of resources are spent to no good outcome, and very, very bad for the whole family and the patient. So it's all of those things. And Reggie's right, we're just starting to begin to scratch the surface on that and make sure that it is the value proposition of what we're offering.
And we've been talking about relationship deepening and partnerships, and this work needs to be in partnership between the systems, the communities, both at the local level government and the state government. It doesn't always feel that way. Sometimes it feels like it's us against them or you against us. And that sort of feeling that is really critical to get past, because the problem is that there is a lack of access based on affordability. There are people who are making choices that they shouldn't have to make about not going to the hospital, not getting the procedure, not getting the screening, that is real. That is real in Connecticut. We have seen it in household surveys that we've been part of for a number of years, and we have to work on addressing that if we're really going to have a health system that works for everybody, right?
Yeah, and Francis, if I could just add one more party to that. Sure. That's needing the partnership, and those are the payers, so the insurance company. This is the insurance company.
Absolutely.
Of the world.
I didn't intentionally leave them out.
Yeah. So the Aetnas, the Anthems, the Cignas, the Blues, they need to all be at the table, and they need to own some of our lowering of the cost of healthcare as well. Yes. Because without them at the table, we won't be successful.
Mm-hmm. Yeah. Well, we're coming up on the last 10 minutes, and there's another question I want to pose to you, because it goes back to the points you both made about the public health infrastructure and how we don't have one. And the question is it's really about what hospitals could do to increase Connecticut's investment in public health, specifically upstream investments to promote health among kids and families that will prevent the next pandemic, and not just medical and technological or vaccine related fixes. What do you think?
Yeah, so what comes to mind immediately is social determinants of health. So let me just take a step back. I'm going to be repeating myself because I'm still talking about systems, but it's not a coincidence, Francis, that the hot spots in the state of Connecticut were mostly brown and Black communities. So one may ask themselves, well, the pandemic affected everyone. How did they become hotspots? Well, you got to take a step back 30, 40, 50, 60 years ago. And if you were really serious about understanding it, and this is really the crux of the matter, this is what has to be addressed, then you got to understand systemic racism and the policies that were put into place that created such populations and the disadvantages that they've had, which led them to become hotspots, right? Mm-hmm. So another silver lining for the pandemic was reminding the entire globe about equity and equality. And when you don't address those seriously, then this is what you get. And again, we can't afford to leave one person or one community behind, because as long as those the fundamental issues aren't addressed, then again, we're going to always have many pandemics. And then I don't know, it's probably not going to be 100 years from now like this one was since the Spanish flu, but we will have these kind of conversations in the very near future. So we've got to be, we've got to be the leaders that this country calls us to be and address the root of the problem. And I'm just afraid that that's not going to happen. But those that are interested in moving this agenda forward have to continue to remind those leaders in any aspect of our state that we got to look in the rearview mirror, see what's happened in the past, and undo those misbehaviors so that we as a state can be a much healthier entity.
Yeah, I agree. And I think the only way to begin to work on this is to also pool resources. So working together collectively. There is no one who has the ability to have a huge influx of new money to create a public health infrastructure. But if we work collectively between the existing resources, and not just hospitals, but clinics and physicians' offices and every single provider of healthcare, and work closely with community and government agencies to create that structure, we are stronger. We learned we are stronger together, and we can have a much bigger impact rather than competing with each other. Decide on what the goal is, to what Reggie was saying, improving the health status of the community, and especially for those who are most vulnerable and have been left behind. And then let's collectively pool our resources and set that goal and work towards improving it.
So, I asked you a question at the beginning about how all of this has changed the two of you as leaders. And on this point about these partnerships, what is needed, well, what's needed is also courageous leadership. And it starts with the people at the top, right? It starts with all of us who have influence and exercising our influence in steering toward these kinds of directions. How have you changed? How has you both have described yourselves as apolitical, but I actually think that without talking about partisan politics, because that's not what I'm talking about. It's the lowercase p political. It's about the community. It's about making change. It's about using policy and influence to make change. And that's what you've just both described with regard to the role of public health, how everybody has to come together. What can you lead your organizations to do to make that happen?
So two things that I've done that are different or more amplified, may I say, than before. I've insisted that every single senior leader on my team get involved in a community agency, get on their board, attend their community meetings, hear their voice, and make sure that we know what is going on out there and that we're listening and that we can have impact. The other is that I've become a little more, now that the pandemic is not where it was before, like I'm sure Reggie had to do the same thing during this period of time. We had to hunker down and focus within to make sure we were taking safe, good care of patients during the biggest public health crisis we will ever experience, I hope, in our lives. But now I'm really out in the community. I'm become evangelical on talking about these things, because I think that we do have a voice around our experience, our knowledge, and our ability to effectuate change. So meeting with business leaders, with other community agencies, with legislators, and telling our story and really trying to co-opt them into making it important for their future, I think is the way that I feel I have changed and my organization has changed.
Thank you.
Yeah, so similar to what Kathy said, and what I'm going to describe quickly now is not just local to Trinity Health New England, but it's the entire Trinity Health organization, which spans 23 states. So one, we had 4 core values. Since the pandemic, we added safety as a core value. So now we have 5. We created a brand promise, which I'm sort of repeating myself. It is our company's brand promise to listen to, partner with, and make it easy for the members that we serve. And we define our membership as the patients we care for, the clinicians that we partner with, and the rest of our colleagues. And then we are incentivized through our balanced scorecard, all of leadership within Trinity Health and Trinity Health New England, by participating in online cultural proficiency and anti-racism courses. Like the state of Connecticut did, Trinity Health publicly was the first national company, healthcare company, to declare racism as a public health crisis. So very proud of that. And then locally and personally, my commitment was to the state of Connecticut to offer or provide what I call education through explanation. When you think about the so-called vaccine hesitancy, for example, I argued that, and you may have heard me argue this, I argued that not having access to a vaccine is not equal vaccine hesitancy, but many of the leaders would publicly say this particular community is hesitant. That's not hesitancy. When I don't understand how the virus works and how the vaccine works, that's not hesitancy, right? That just requires the time for someone to answer my question and address my concerns. So I have made and continue to make a personal commitment to make myself available to provide education around this pandemic through explanation.
That's really, really, really critical, and it is so important. There was a question in the chat about vaccination hesitancy among healthcare workers, right? And so much of it is misinformation and misunderstanding, and the need for people who are influencers, right, like yourselves, to come forward. I will also say, right, that there's a monetary investment necessary in all of this future infrastructure we need to build, and that the hospital systems are in a unique position. And I understand margin. I understand that. I've served on the board of a hospital myself. So I do, and particularly on the finance committee of that hospital. So I do understand the margin versus mission issue. However, there are resources and access to resources that systems have that can be lead investments, right? And we saw some of that in the 90s in Hartford, actually, around affordable housing. So Hartford Hospital investing directly in the production of affordable home ownership for people in the community, and in other investments to help people get jobs that could put them on a career path. And when we all work together on that kind of an agenda, everybody benefits, right? Because the hospital is a member of the community and isn't as easily able to pick up and move as a corporate resident might be able to, right? A company might be able to say, oh, well, we're moving from Fairfield County, Connecticut to Boston, Massachusetts. But you all can't quite do that. And so it is both an opportunity and a challenge, right, to meet the future. So I'm going to stop on this note. Thank you both so very much. I hope that our audience has enjoyed this conversation, has learned from the conversation. There are some questions we didn't get to, but that always happens to us. We run out of time. This is easily a much longer discussion. I just want to thank everyone for joining us today. You should watch for an email with a survey asking you to evaluate the program. We'd like to hear from everybody. And we will have links to the conversation on our social media. So please, if you don't already follow us on Facebook, Instagram, and Twitter. We have another program coming up on November 17th, and that one is going to be on behavioral health. I hope you'll both join us as members of the audience then, because you clearly have work that you're doing in this area, but watch your emails and social media to register. So on that note, thank you, everyone, and enjoy the rest of your afternoon.
Thank you.
Take care.
Bye-bye.